We are going to continue with the study of DNA viruses, but we have to do something before that. Look. We follow this picture for the study of viruses. We have studied DNA viruses with envelope double-stranded. We have studied herpes viruses and hepatitis B. Unfortunately, it's very sad, but we don't have enough time to study pox viruses. We don't have time, so we don't say anything about them. Now, we are going to study viruses without envelope, starting with papillomaviruses, that they are the most important. And later we will study parvoviruses, single-stranded. But before that, we are going to study hepatitis D. Hepatitis D is not a DNA virus. Hepatitis D is an RNA virus. We study now hepatitis D because hepatitis D is always related with hepatitis B. So we have to study hepatitis D now. So we are here. We are going to study hepatitis D. Hepatitis D virus is not exactly a virus. We say that it's a satellite virus. What is that? Satellite virus means that hepatitis D virus infection is always related with hepatitis B virus infection, always. So hepatitis D virus can replicate independently. Hepatitis D can replicate alone. However, hepatitis D virus requires hepatitis B for complete assembly and release. So patients infected with hepatitis D are always infected with hepatitis B. Patients infected with hepatitis D are always infected by both D and B. Hepatitis D virus is only found in patients who are also infected with hepatitis B. Hepatitis D virus is transmitted by the same mechanisms as hepatitis B. But the most important is parenteral transmission through the blood. Sexual transmission is possible. Mother to child transmission is also possible, but both are very rare. The most common way of transmission of hepatitis D is parenteral transmission through the blood. Around 5% of people in the world who are already infected with hepatitis B are also infected with hepatitis D. What about in Vietnam? We don't know very well. I have been searching medical papers to find how many people are infected in Vietnam by both hepatitis B and D, and I found that around 10.7% of people in Vietnam who are already infected by hepatitis B are also infected by hepatitis D. This is the source that I found, if you are interested to read it. And I found a different medical paper, and they say that hepatitis D virus is mostly found in the north. In the north, it seems that around 15% of people chronically infected with hepatitis B are also infected with hepatitis D. And this is the source, the medical paper, if you want to find the information. So in Vietnam, it seems that around 11% of chronically infected hepatitis B people are also infected by hepatitis D. Don't forget, hepatitis D virus is always found with hepatitis B virus. What about the structure of the virion? The structure of the virion is very simple. The nucleic acid is very small. The nucleic acid is made of single-stranded RNA. Remember, single-stranded viruses may be classified either as positive or negative. This one is negative, so they belong to Baltimore group number 5. Negative single-strand RNA, very small. They don't have capsid. no capsid. They have envelope, and this envelope is very interesting. This is the nucleic acid, negative single-stranded RNA. This is the envelope, and the envelope contains glycoproteins for binding host cell receptors. And this envelope is very important, it's very interesting, because these glycoproteins are the surface antigen of hepatitis B. So hepatitis B surface antigen is found in the envelope of hepatitis B virus. And the antigen is also found in 3 forms, the small, medium, or large, the same as hepatitis B. So this is the virion, and these blue things that I show you here, this is not the capsid. These blue things, these blue circles, are proteins, and these proteins are called hepatitis D antigen. This protein, hepatitis D antigen, is the only protein contained in the nucleic acid. This is called the delta antigen, hepatitis D antigen, the only protein encoded by hepatitis D virus, the only one, surrounding the nucleic acid in two forms, small one and large one, but this is not important for you. What about the damage by hepatitis D virus? What about the damage? It seems that, like hepatitis B, most damage depends on the immune response. Patients infected with hepatitis D and hepatitis B, with both, may suffer more severe complications with higher mortality and higher morbidity. So, chronic infection by both viruses is more severe than chronic hepatitis B alone. And we have 2 possible scenarios of infection. First one, the first scenario is called co-infection. What is co-infection? Co-infection means both viruses, B and D, are acquired at the same time during the same exposure. So the patient was healthy before, and the patient becomes infected by both viruses at the same time. This is called co-infection. And what happens to the patient? The patient will suffer acute hepatitis. Acute hepatitis by both viruses at the same time. Acute hepatitis by B and D viruses at the same time. And what happens later to this patient? Most times, the patient will recover completely from both viruses. So, in most cases, both viruses will disappear. In most cases, but not always. Sometimes the patient will become chronically infected by both viruses. I'll show you later. So this is the first scenario. Both viruses are acquired during the same exposure at the same time. The second scenario is called superinfection. What is superinfection? Superinfection is a patient who is already chronically infected by hepatitis B becomes infected by hepatitis D. So the patient was not healthy. The patient was infected by hepatitis B virus. The patient becomes infected by hepatitis D. This is superinfection. And what happens to this patient? Mostly, the patient will become chronically infected by both viruses. Do you understand the difference between both scenarios? Do you understand the difference between co-infection and superinfection? Any question about the difference between co-infection and superinfection?
Yes.
Question? Any question about the difference between co-infection and superinfection before we continue?
No.
So you understand the difference between both? Okay. So we are going to study with a picture both scenarios, easier than this one. So the first scenario, co-infection. Co-infection means hepatitis B virus and hepatitis D virus are acquired at the same time, in the same exposure. What happens to this patient? Most times, more than 95% of times, the patient will recover completely. The patient will be cured both viruses. Both viruses will disappear. This is the most common outcome. However, in less than 5% of patients, the patient is not recovered, and the patient becomes chronically infected by both viruses, hepatitis B virus and hepatitis D virus. So this is the first scenario, co-infection. What about the second scenario, superinfection? Superinfection means hepatitis D virus infection on a chronically infected hepatitis B virus infection. What happens to this patient? Most times, about 90% of times, this patient will become chronically infected by both viruses, hepatitis B and hepatitis D, most times. However, around 10% of patients will be cured of hepatitis D virus, but not B virus. So they will remain chronically infected by hepatitis B virus. They were chronically infected by hepatitis B virus before, and they will remain chronically infected by hepatitis B virus, but not hepatitis D virus. Do you have any question about this picture?
No.
You want to say something about this? Or is clear? I'm not sure if this is clear. Anyway, so we have three possible outcomes. We have three possible outcomes. Patients cured by both viruses. This is the most common outcome after co-infection. Patients chronically infected by both viruses. This is the most common outcome after superinfection. And patients cured of hepatitis D, not hepatitis B. This is an outcome after superinfection, but not common, just 10%. So you understand this picture. Okay. So if we understand this picture, we are going to follow. Chronic hepatitis D, well, chronic hepatitis D means chronic hepatitis D and chronic hepatitis B at the same time, because hepatitis D alone is not possible, okay? So chronic hepatitis D, that means chronic hepatitis D and B, is more severe than hepatitis B alone. These patients with chronic hepatitis D and B have higher risk of complications, more cirrhosis, higher risk of liver cancer. And we have some patients infected by three viruses at the same time: HIV, hepatitis B, and hepatitis D. In these patients infected by three viruses, the liver disease is even worse. How can we make the diagnosis of hepatitis D virus? Using the same methods as hepatitis B virus. Serology. So detection of antibodies against the delta antigen. And we can detect IgM or IgG. Remember, this is from the second class. IgM is the first antibody that appears. So IgM is very useful in the diagnosis of acute infections. IgG appears later. So serology, detection of antibodies. And detection of RNA, detection of the nucleic acid by PCR. So we have two tests for the diagnosis of hepatitis D, the same as hepatitis B, serology and PCR. Okay, so we are going to differentiate different profiles by using serology. So look, so we are here. These are the tests that we are going to use for the diagnosis of hepatitis B. I'm going to change the color of this because this is hepatitis B. Okay, so look. So patients infected with hepatitis B are always infected by hepatitis B, okay? These are the markers that we are going to study, in patients infected with hepatitis B. The markers related with hepatitis B, the surface antigen, antibodies against the surface antigen, and IgM against the capsid. Hepatitis B. Markers to study hepatitis D, IgM against the delta antigen, IgG against the delta antigen, and the RNA by PCR. And we can find 4 or 5 different profiles. So look, patients with co-infection that are infected by hepatitis D and hepatitis B at the same time. How is the profile that we find at the laboratory of microbiology? What about the markers of hepatitis B? This patient is currently infected by hepatitis B, so the surface antigen is positive. It's not protected, so antibodies against the surface antigen are negative. And this patient is in contact with hepatitis B virus, acute infection, so the IgM against the capsid is also positive. So these are the markers related with hepatitis B virus. What about the markers for hepatitis D virus? The patient is currently infected right now, so the virus is replicating. So the RNA is found in the blood. So the RNA is positive. The IgM against the delta antigen is also positive. And when the patient comes to the hospital, the patient is already producing IgG. So these are the markers that we find in a patient with co-infection right now, when the patient is infected by both viruses at the same time. What happens to this patient with co-infection? What happens? As I told you before, most of these patients become recovered. Most of these patients recover completely. Most of them cure. So what's the profile in a recovered patient? The surface antigen becomes negative because the patient has recovered from hepatitis B. Antibodies against the surface antigen become positive because the patient has recovered. So the patient becomes protected against hepatitis B. And the IgM against the capsid also disappears because the patient is recovered from hepatitis B. So this is the profile of a recovered patient after co-infection with hepatitis B and hepatitis D. And what about the markers of hepatitis D? Because the patient is recovered, the RNA disappears from the blood. So the RNA becomes negative. What about the IgM? The IgM also becomes negative. The IgG remains positive because IgG remains always in all infections. However, in these patients, after several months, the IgG may disappear and become negative. So this is the profile of a patient who has recovered from co-infection. Second scenario, superinfection. So this patient is already infected by hepatitis B. So the surface antigen is positive, antibodies are negative, and the IgM against the capsid is also negative. This is the profile of a patient with chronic infection, okay? Hepatitis B. This patient is chronically infected with hepatitis B. So what about the markers of hepatitis D? The RNA is found in blood because the patient is infected right now with hepatitis D and the virus is replicating. What about IgM? The IgM is also positive because the patient is infected right now with hepatitis B. And the IgG, when the patient comes to the hospital, the IgG is also positive. So look, this is the typical profile of a patient with superinfection. So this is a patient who was already infected with hepatitis B that becomes infected now with hepatitis D. This is called superinfection. What happens to this patient with superinfection? Most of these patients become chronically infected by both viruses, B and D. So what about the markers of hepatitis B virus? No change. The surface antigen positive, antibodies against the surface antigen negative, and IgM against the capsid negative. So this is chronic hepatitis B virus infection. What about the markers of superinfection, chronic? What about the markers? No change. The RNA is detected in blood because the patient is chronically infected by both. What about the IgG? Also positive because the patient is infected by both viruses, so the IgG does not disappear. And now we have something interesting. For most viruses, for most patients with chronic viral infections, the IgM disappears. That's usual for most chronic infections. However, in the case of hepatitis D virus, the IgM does not disappear. And this is not common. This is very rare. But in the case of chronic hepatitis D virus infection, the IgM does not disappear. And we don't know exactly why. However, the level is lower than in acute infections. So the profile is almost the same for both. And finally, we have some patients, but not many, just around 10% of patients, that become recovered of hepatitis B virus after superinfection, not hepatitis B. So hepatitis B markers are the same. They remain chronically infected by hepatitis B, but they recover from hepatitis B. So the markers become negative. So the nucleic acid is not detected in blood, disappears. The IgG usually remains positive because IgG remain positive forever. Maybe sometimes the level of IgG may decrease, but we are not going to say anything about that. Just to remember that the IgG remains positive and the IgM becomes negative. So this is the profile of a patient cured from hepatitis D virus after superinfection. Just to tell you that this IgG may decrease or even disappear, the same as this case. Okay, so these are the profiles that we can find in patients infected with hepatitis D virus. Do you have any question about this before we continue? Because this is very important. This is what we do at the Laboratory of Microbiology. Any question? Oh, do you want to say something?
If they have question. Ờ, Ở trong cái bảng này là thầy nói cho các bạn về hai cái trường hợp là đồng nhiễm tại cùng một thời điểm, và trường hợp thứ hai đó là bệnh nhân viêm gan B sau một thời gian thì nhiễm thêm cái viêm gan D. Chúng ta nhớ là cái virus viêm gan D là cái virus gọi là virus vệ tinh, có nghĩa là tự bản thân nó không thể xâm nhập vào vì nó không có cái cấu trúc vỏ bên ngoài các bạn. Thì chúng ta quan sát thấy cái cấu trúc của nó thì cái vỏ bên ngoài của nó là nó mang cái lớp vỏ của cái virus viêm gan B, có nghĩa là nó tận dụng cái cấu trúc vỏ của virus viêm gan B để mà nó thành một cái, nó sử dụng như là một cái phương thức để nó có thể xâm nhập vào. Do đó thì chỉ có những cái bệnh nhân mà nhiễm virus viêm gan B thì mới có khả năng bị nhiễm bởi virus viêm gan D. Thì cái trường hợp đó là đồng nhiễm thì đó là nó đồng nhiễm, nhưng mà hầu như là bệnh nhân đó sẽ nhiễm virus viêm gan B sớm hơn một thời điểm so với virus viêm gan D, và sau đó thì virus viêm gan D mới có thể xâm nhập vào được. Thì đối với cái trường hợp mà đồng nhiễm bởi virus viêm gan B và D cùng một lúc á, thì đa số nó cũng giống như là việc mà nhiễm đối với viêm gan B, có nghĩa là cơ thể chúng ta có cái hệ miễn dịch mạnh mẽ và đa số là chúng ta sẽ phục hồi với cái tỷ lệ rất là cao. Nhưng mà vẫn có một số cái trường hợp, vẫn có một cái tỷ lệ thấp, đó là cả viêm gan B và viêm gan D đều chuyển qua ở dạng mãn tính cả. Và trường hợp thứ hai đó là sau một thời gian khi mà bệnh nhân bị nhiễm viêm gan B rồi thì sẽ có khả năng, có nguy cơ bị nhiễm viêm gan D. Thì đối với trường hợp đó thì đa số các cái trường hợp là sẽ chuyển cái viêm gan D qua dạng mãn tính luôn, và một số trường hợp là bệnh nhân sẽ bình phục đối với viêm gan D. Nhưng mà nhớ là vì viêm gan B nó ở dạng mãn tính rồi cho nên là hầu như là nó không có bình phục đối với trường hợp của viêm gan B nữa mà.
Ôi cô.
Cô nghe đấy.
Nãy thầy có nói về cái việc mà khi mà cái super infection mà nó chuyển sang mãn tính rồi đấy, thì cái kháng thể là anti IgM nó có khả năng biến mất luôn như là sao?
Tức là cái cuối cùng đúng không em?
Cái thứ hai, cái chronic 90% đấy.
Cái super infection
Cái
90%.
Dạ.
Rồi em nói lại giúp cô.
Thế em có nhớ là thầy nói là có cái gì liên quan đến cái anti HDV IgM nó có khả năng như là nó biến mất khi mà bệnh này đã chuyển sang mãn tính không?
Tức là em nói cái anti HDV IgG hả, hay là IgM?
IgM của.
Tại vì em biết á, cái IgM là cái kháng thể mà xuất hiện đầu tiên trong nhiễm trùng, có nghĩa là khi mà một cái tác nhân vi sinh vật tấn công vào bên trong cơ thể chúng ta thì kháng thể đầu tiên xuất hiện là IgM, và sau đó một thời gian thì cái IgG nó xuất hiện, và cái IgG này nó sẽ thay thế hoàn toàn với cái IgM đó, có nghĩa là IgM thông thường nó sẽ không tồn tại trong bệnh nhân mãn tính, nó chỉ thường là tồn tại ở dạng cấp tính thôi. Do đó khi mà người ta xét nghiệm người ta phát hiện IgM thì thường đó là một cái marker để người ta xác định là nó ở dạng cấp tính. Nhưng mà trong trường hợp này nó là dạng mãn tính nhưng mà vẫn thấy xuất hiện IgM, cho nên thầy mới nói đây là một cái trường hợp nó rất là lạ.
Cảm ơn cô.
Rồi.
No questions about serology of hepatitis D and B? Okay. So how can we prevent hepatitis D infection? Using the vaccine against hepatitis B. Okay. So we can prevent co-infection. We can prevent co-infection by vaccinating against hepatitis B, obviously. However, we don't have any vaccine to prevent superinfection. So that is the problem, the prevention of superinfection. These patients are infected already by hepatitis B virus. So the vaccine against hepatitis B virus in these patients is useless. Currently, we don't have any vaccine against hepatitis D virus. But maybe it's possible to make a vaccine. Maybe it's possible to make a vaccine with using the Delta antigen, but we don't have yet. So in the future, we hope to have a vaccine against hepatitis D, and hopefully we can use this vaccine in patients chronically infected with hepatitis B. but currently we don't have. So remember, the prevention of the spread, the transmission of hepatitis D is made by using the same mechanisms as for hepatitis B. So safe sexual practices, not sharing needles, not sharing razors, toothbrushes, not donating blood. So the measures to prevent the spread are the same as for hepatitis B, because both viruses are transmitted by the same mechanism. Okay, so now we can continue with the study of other DNA viruses. So we are here. We continue now with the study of non-enveloped DNA viruses, double-stranded. In this group of viruses, we have three. Papilloma viruses, the most important. Polyoma viruses, and both are very similar. Papilloma and polyoma are very similar. But we study only papilloma viruses because we don't have time to study polyoma viruses. And finally, we have adenoviruses that we are not going to say anything about them because unfortunately, we don't have time to study them. So in this class, we are going to study only papilloma viruses and adenoviruses later. Okay? So this is where we are. We are here. Before we study with papilloma viruses, papilloma viruses and polyoma viruses are very similar, as I told you before. In some old textbooks of microbiology, not now, but in the past, both viruses were studied together, and they were called papovaviruses. Pa from papilloma, po from polyoma, papovaviruses. But currently, we study them in two different families. We don't say anything about polyoma viruses because unfortunately, we don't have time to explain them. But I want to say something very briefly about polyoma viruses. Polyoma viruses are usually asymptomatic in immunocompetent patients. However, they may cause severe diseases in immunocompromised people, so they are opportunistic. The most important polyoma viruses in humans are two, the BK virus and the JC virus. Both infect immunocompromised people. The BK virus causes severe kidney disease, severe renal disease in transplant patients. JC virus is the cause of a central nervous system disease called progressive multifocal leukoencephalopathy, PML. This disease is found in patients with AIDS, in HIV positive patients, so immunocompromised patients. Polyoma viruses are opportunistic. And now we start with papilloma viruses. Papilloma viruses. The target host cells infected by papilloma viruses are epithelial cells, stratified squamous epithelia. You will study the different epithelial cells in histology. I don't know when. Next year, maybe. These are stratified squamous epithelia that you will study in histology. These epithelial cells are found in the skin and in mucosas. The target host cells infected by papilloma viruses are stratified squamous epithelia, like this, in the skin or in mucosas. Papilloma viruses are oncogenic. They can cause cancers. So currently, you know 4 viruses that are oncogenic. Papilloma viruses, hepatitis B, Epstein-Barr, and Kaposi sarcoma virus. You already know 4. Papilloma viruses cause tumors. These tumors most times are benign. However, sometimes, not many, these tumors are cancers, so malignant tumors. The most important, the cervical cancer in women. That is the most important disease caused by papillomaviruses. Human papillomaviruses is related with most cervical cancers in women, almost always. Almost 100% of all cervical cancer in women are caused by papillomaviruses, almost all. So look, papillomaviruses, sorry, I am going to write here. Papillomaviruses may cause different diseases in different places. So, papillomaviruses may infect either the skin, so cutaneous infections, or mucosas, the skin or mucosas. These infections may be either genital infections transmitted by sexual contact or non-genital infections. Usually the hands or the feet. And these diseases, these infections, may be either benign or cancers, malignant. And all combinations are possible, okay? So skin or mucosas, genital or non-genital, benign or malignant. All combinations are possible. The most important problem of papillomaviruses are the cancers in genital locations. The most important cancer is the cervix cancer in women. This is the most important, but not the only one. They can cause other cancers. So look, this is a picture from the Netter Atlas of Anatomy. In my opinion, one of the best atlas of anatomy. And this is the uterus in women. This part of the uterus is the cervix. The cancer appears here in the cervix. Papillomaviruses are transmitted by contact, directly or indirectly. Directly, from person to person, from body surface to body surface, including sexual contact. So, papillomaviruses are another sexually transmitted infection. Contact from person to person. However, they are also transmitted by the contact with contaminated surfaces. Very common in the showers or in the swimming pools. So, indirectly. Genital infections are the most important. As I told you before, human papillomaviruses is possibly the most common, the most prevalent sexually transmitted infection in the world. More than 50% of people who have sexual relations will become infected in their life. Most of the sexually active people is likely to be infected in their life. The most prevalent sexually transmitted infection. The problem of this sexually transmitted infection, the problem is the cancer in women. The problem is the cervical cancer. The cervical cancer is the fourth most common cancer in women. The fourth. However, cervical cancer is the second leading cause of death cancer in women. The second. The first one is the breast cancer. The second one is cervix cancer. And most of these deaths, more than 85% of these deaths, occur in poor countries, unfortunately. We have many different types of papillomaviruses. Not all cause cancers. So I am going to divide these types into 3 types. So different serotypes, different types of papillomaviruses. Papillomaviruses types. We have 3 groups. Some of them cause cancers, but not all. I will tell you later. So the first group of diseases, the first group of types of papillomaviruses are those who cause warts, the common warts. Common warts in the skin, in non-genital skin. These common warts are caused by the serotypes 1, 2, 3. These are the most common, also 4, sometimes 10, but these 4 are enough to remember, 1, 2, 3, and 4. And some of them, types 6 and 11, they cause disease in mucosas, so in the larynx, and genital disease, the skin or mucosal, genital or skin. Sorry, skin or mucosas, genital or non, mucosa, genital or non-genital. Genital disease, skin or mucosas. So the genital disease, not cancer, in the skin or in mucosas is mostly caused by type 6 and type 11. The disease in other mucosas, for example, in the larynx, is also caused by 6 and 11. And finally, the cancers. Many different types of papillomaviruses may cause cancers, but the most common are 16 and 18. These are the types that you must remember. 16 and 18 cause cancer, but also others that we are not going to mention here. So 3 types. The most important to remember, cervix cancer. The most important cancer is the cervix, but not the only one. I told you that the most important problem of papillomaviruses is the cervix cancer in women, but sometimes men can also suffer cancers in the penis, in the anus, in the larynx. Not common, but also possible. The most common is the cervix cancer, but not the only one. So remember 16 and 18. Papillomaviruses 16 and 18 cause more than 70% of cervix cancer, but not all. Around 30% of cancers are caused by other serotypes that I show you here, that you don't have to remember. Just remember 16 and 18. This is the structure of papillomaviruses. They don't have envelope. This is the capsid. So look, they have the nucleic acid, double-stranded, so 2 molecules of DNA, double-stranded. This is the capsid, icosahedral. The capsid is made of capsomers, small proteins, and these capsomers are 2 different types of proteins, the L1 and the L2. You don't have to remember the names of these proteins, but I have to tell you that the L1, so this, the L1 protein, is the protein that the virus needs to bind host cell receptors. But you don't need to remember this. The L1 protein is the protein for attachment, for binding host cell receptors. Found in the capsid. They don't have envelope. These diseases are more severe in immunocompromised people. The immune system can fight efficiently against papillomaviruses. Warts, the common warts, may disappear after a few months. So they don't disappear immediately, but the immune system can fight efficiently. Not always, obviously. Immunocompromised people may suffer more severe diseases. These are common warts in the skin. Very common for everyone. I think most people have been infected by papillomaviruses. Most people. This picture is not usual because this patient has many lesions. This is not common. It's very common to have 1 or 2 or 3, but not so many. So possibly this patient is immunocompromised. And this one the same. This is a very large lesion. This is not usual. So maybe this patient is also immunocompromised. This is much more common. This is very common. Papillomaviruses, the common warts in the skin, very common. All the people have suffered. Or this one, very common in the fingers. This is the appearance when we look very close to them. And this location is also very common in the feet. Here, exactly here. And this location is painful. They are usually transmitted when we walk barefoot in a contaminated shower or in a contaminated soil, for example, in the swimming pool. This is extremely common. I have suffered many times in my life. Very common and painful for several months. This is the same location. Transmitted by contact when walking. This patient is immunocompromised. This patient is transplanted. So because they are immunocompromised, the lesions are more severe, like this one. And this is a lesion in the larynx. This is a mucosal lesion in the larynx. Some of them may become cancers, some of them. And this is the penis in a man, transmitted by sexual contact. So possibly this is a serotype 6 or 11, or in the anus, possibly serotype 6 or 11. But the problem is this, the problem is the cervix, the cervical cancer, transmitted by sexual contact. We don't have any antiviral treatment against these diseases. So the common warts, the skin warts, are treated usually by surgery or using cytotoxic drugs, not antivirals, or cryotherapy with cold therapy that I don't show you here. Cancers require a very important surgery, radical surgery, combined with radiation therapy that you will study in the future. So we don't have any treatment, we don't have any antiviral treatment for cancers. The best way to prevent transmission is safe sexual practices. So the use of the condoms by males. This is the same as for preventing other sexually transmitted infections. Safe sexual practices. Currently, in the last 12 years, we have vaccines against papillomaviruses. The antigen that we use in the vaccine is the L1 protein, because this protein is the protein that the virus uses for binding host cell receptors. Currently, we have 3 vaccines against papillomaviruses. The first vaccine that appeared 12 years ago was a vaccine only against serotype 16 and 18. So the most important serotypes that cause cancers. So it was called the bivalent vaccine. Bi means 2, because it's against 2 serotypes, 16 and 18. Later, the quadrivalent vaccine appeared. Quadri means 4, because this vaccine was made to fight against 4 serotypes. 16, 18, of course, and 6 and 11. And 2 years ago, or 1 year ago, very, very recently, the 9-valent vaccine appeared, because this vaccine fights, prevents 9 different serotypes. 6-11, 16-18, of course, and other serotypes that are also related with cervix cancer. This vaccine is given in 2 doses or 3 doses, depending on the age of the recipient. If you are interested in the dose, at the end of the presentation in complements for better understanding, I show you how to give these vaccines. These vaccines have proved to be very effective, 100% effective, and very safe. Currently, the World Health Organization recommends the vaccination of girls between 9 to 14 years old. In many countries, we are vaccinated females from 9 to 26 years of age. These vaccines should be given before the first sexual relationship to prevent the transmission, to prevent the infection, of course. In some countries, males are also vaccinated because these diseases also appear in males. If we prevent the disease in males, we can also prevent the disease in females because of sexual transmission. So some countries have started vaccinating males. The quadrivalent vaccine and the 9-valent vaccine is also effective in men, because these serotypes, 6 and 11, cause disease in men. So currently, the recommendation in Vietnam is to vaccinate women, currently. However, in some countries, males are also vaccinated. Any question about papillomaviruses before we continue? You want to say something? Or the vaccine in Vietnam?
Thầy vừa giải cho bạn nghe về cái con virus HPV mà chúng ta thường hay nghe về cái tác nhân gây ra ung thư cổ tử cung đó bạn. Tuy nhiên thì các bạn nam mình cũng lưu ý là đây không chỉ là tác nhân gây ra cái ung thư cổ tử cung ở nữ giới, nó còn vẫn có khả năng gây ra các bệnh ở nam giới. Ví dụ như các bạn biết bệnh sùi màu gà, biết bệnh đó không ạ? Bạn nào mà chưa biết thì lên mạng coi về hình ảnh của nó để mà biết thì gây ra các cái bệnh lây qua đường tình dục. Và thường thì chúng ta nói đến HPV thì bạn nghĩ là nó chỉ lây qua đường tình dục và gây bệnh ở các bộ phận sinh dục. Tuy nhiên thì cái virus này khi mà nó đào thải ra ngoài môi trường, vì bản chất của nó là nó không có cái lớp vỏ envelope, cho nên là nó có thể rất là bền vững ở ngoài môi trường. Nó có thể có ở trong phòng tắm này, hoặc là các cái bề mặt, ví dụ như là bàn tay, nắm cửa, vân vân. Cho nên là khi mà chúng ta có các cái vùng trên cơ thể, ví dụ như da và niêm mạc có các cái tổn thương nhỏ thôi, và nó có tiếp xúc với các cái bề mặt có chứa virus này, thì nó có thể xâm nhập vào và nó gây nên các cái mụn sinh học hoặc là mụn cóc, như hình ảnh mà các bạn thấy đó. Thì thông qua các cái vết như vậy, các cái vết thương nhỏ như vậy, thì virus nó có thể tấn công và nó tạo ra cái sự tăng sinh của các tế bào và hình thành nên các cái mụn cóc như vậy, các cái mụn sinh học. Mà đặc biệt là tùy theo mỗi tiếp virus khác nhau mà nó sẽ có cái cơ chế gây bệnh khác nhau. Thầy cũng có phân biệt cho bạn đó là đối với mụn sinh học thì những cái tiếp nào, đối với ung thư cổ tử cung thì nó sẽ có những cái tiếp gây bệnh nào, và tùy theo cái mục đích mà chúng ta phòng ngừa mà người ta sẽ có các cái loại vaccine khác nhau. Ví dụ ở Việt Nam chúng ta thì nó có 2 cái loại vaccine phổ biến, đó là cái vaccine mà chứa 2 cái tiếp là 16 và 18 đó bạn, để có thể phòng ngừa được ung thư cổ tử cung. Hoặc là một số trường hợp thì người ta sẽ tiêm cái vaccine mà gồm có tổ hợp gồm 4 cái tiếp đó, vừa có thể phòng ngừa được ung thư cổ tử cung mà vừa cũng có thể ngừa một số cái lây nhiễm gây ra các cái mụn sinh học. Thì trong cái quá trình điều trị á, thì hầu như hiện nay chúng ta chưa có các cái thuốc để chúng ta có thể tiêu diệt được virus. Chủ yếu là chúng ta điều trị các cái triệu chứng. Ví dụ như là các cái mụn sinh học thì có thể là người ta sẽ sử dụng nitrogen lạnh, có nghĩa là cái liệu pháp dùng nitrogen lạnh để người ta có thể loại bỏ các cái mụn sinh học đó, hoặc là người ta có thể sử dụng cái phương pháp đó là mổ laser để chúng ta có thể loại bỏ, hoặc là sử dụng các cái thuốc có thể sử dụng theo đường uống để chúng ta có thể hủy hoại các cái mụn sinh học. Còn đối với cái vùng ung thư cổ tử cung thì có thể là sử dụng theo phương pháp đó là phẫu thuật để chúng ta loại bỏ, và tùy theo cái mức độ cái mức độ ung thư tổn thương ở cái vùng cổ tử cung đó mà người ta sẽ có cái phẫu thuật với cái kích thước cái phương pháp mổ làm sao cho nó hạn chế tối đa cái vùng ung thư đó của bệnh nhân. Và đa số các cái trường hợp hiện nay là chúng ta sử dụng vaccine thì các bạn nữ lưu ý là hiện nay thì cái vaccine này sử dụng ở Việt Nam chúng ta là không nằm trong chương trình tiêm chủng mở rộng, mà đa số là chúng ta phải tiêm dịch vụ, có nghĩa là chúng ta sẽ bỏ tiền ra để chúng ta tiêm, và thường là người ta sẽ khuyến cáo ở cái độ tuổi là từ khoảng 9 tuổi ở bé gái trở lên thì người ta đã tiêm rồi. Và thường là chúng ta phải tiêm trước khi mà có quan hệ tình dục, bởi vì qua quan hệ tình dục thì cái nguy cơ lây nhiễm rất là cao. Ở một số cái quốc gia thì người ta cũng khuyến cáo là tiêm cho bé nam. Thứ nhất là không phải là cái HPV này nó gây ung thư cổ tử cung ở cho nữ giới không, mà nó cũng có nguy cơ gây ra ung thư ở một số bộ phận trên cơ thể của nam giới, ở bộ phận sinh dục hoặc là ở đường hô hấp, ví dụ như là lây qua đường tình dục khi mà quan hệ tình dục qua đường miệng chẳng hạn các bạn. Và đồng thời việc mà tiêm vaccine cho nam giới hạn chế cái